Thank you very much to the organizers for inviting me to give a talk on a topic of really great and emerging interest in our pediatric IBD community. I have a few tangentially related disclosures shown here, and importantly, my entire talk involves off-label use. Over the next 20 minutes, we will review the methotrexate mechanism of action and then focus on a couple of selected clinical areas: monotherapy in Crohn's disease, monotherapy in ulcerative colitis, combination therapy with anti-TNF, and safety. Starting with the mechanism of action, you all recall from medical school that methotrexate is a folic acid derivative and as such inhibits the enzyme dihydrofolate reductase. This is critical to purine and pyrimidine synthesis, and when used in high doses, like for chemotherapy, it inhibits DNA production, both through anti-proliferation as well as through cytotoxic effects. The mechanism of action of low-dose methotrexate in the range of 5 to 30 milligrams, as we often use in our pediatric IBD patients, is much less clear, but it is thought to not have such anti-proliferation effects. And this is important in understanding why methotrexate used in our IBD doses does not result in some of the same chemo side effects, such as hair loss. It's speculated that low-dose methotrexate may result in the inhibition of adenosine deaminase with downregulation of adaptive immune responses, or possibly decrease the release of pro-inflammatory cytokines. Bottom line, in the doses that we use for IBD, the mechanism of action of methotrexate is largely unknown. Let's move now to the use of monotherapy in Crohn's disease. And so we all know this, but 5-ASAs are largely ineffective in Crohn's disease, and there are growing concerns regarding the use of 6-MP and azathioprine, both in terms of their effectiveness as well as safety. Biologics are wonderful, but not a panacea. They are not universally effective. There are real safety concerns. There are issues around convenience, whether it's infusions or injections. And of course, the elephant in the room continues to be cost. And we have a fair amount of data now going back several decades that methotrexate is both reasonably safe and an effective treatment for Crohn's disease. And let's review that data together. And of course, you all as a PEDS IBD community are great embracers of methotrexate. This is a slide from the Pediatric IBD Registry showing the increased use of methotrexate over a 5-year period following the FDA black box warning regarding hepatosplenic T-cell lymphomas. And so the story with methotrexate really began in the 1990s when it was first used, and then in 1995 when this landmark clinical trial by Brian Fagan's group was published. And you can see on the left here a fairly robust effect of methotrexate in inducing clinical remission as compared to placebo. The left part of the left figure shows a 20-point absolute risk difference between the methotrexate group and the placebo group. And the effect of methotrexate really seemed similar whether patients entered the study on either high-dose or low-dose prednisone. One thing that's striking to me was the very large difference in the placebo response in the high-dose versus low-dose prednisone group. And I actually asked Brian Fagan about this at dinner last night, and his response was, it's just a subgroup, ignore it and move on. So I think we'll do that this morning. The slide on the right shows a function of CDAI reduction related to time since randomization. And you can see that the curves here begin to separate somewhere around 2 to 4 weeks after methotrexate induction. And again, we typically say that the methotrexate window of action is somewhere in the 2 to 4 week range. This is the data by which we often say that. This is a 2000 study by Brian Fagan's group looking at maintenance of remission. So this was in many ways a parallel and follow-up study to the induction study. And you can see here a relatively robust effect of methotrexate shown at the top compared to placebo shown at the bottom in maintenance of remission. What about pediatric data? While we have no randomized controlled clinical trials of methotrexate in pediatrics, we now have an abundance of observational studies, including multicenter observational studies. This study here was utilized the Prospective Multicenter North American Registry, the Pediatric IBD Registry, and within that registry, the investigators identified 299 Crohn's disease patients who were treated with methotrexate between the years 2002 and 2010. 172 were treated for more than 3 months without concomitant thiopurine or biologics. And as shown in bold, a third of these methotrexate patients achieved 12 months of sustained clinical remission. And as you can see at the bottom, for patients who sustained clinical remission for 12 months, somewhere between 70 and 80% had a sustained clinical remission going out 2 to 3 years. We're all pediatricians. What about growth? This was a nice multi-center retrospective chart review published by Dan Turner now a number of years ago, where he compared height velocity z-scores in the 1 year prior to methotrexate to the 1 year following methotrexate initiation. And he stratified these data by those who had a clinical response or a lack of clinical response to methotrexate. And you can see, regardless of the clinical response to methotrexate, both groups had an improvement in height velocity, although the improvement in height in the patients who had a good clinical response to methotrexate was much more robust. Another question we have to ask ourselves in pediatrics is, if I'm going to use methotrexate for Crohn's disease, should I use oral versus subcutaneous dosing? This was another project by Dan Turner. Again, a different multi-center retrospective cohort of 226 children treated with methotrexate. 17% were treated orally, 43% were initiated on sub-Q dosing and then transitioned to oral, and 40% received sub-Q dosing only. All groups were propensity matched for analyses to take into account the possibility of confounding by disease severity. Overall, across groups, there was a 34% response with sustained steroid-free remission. And after adjusting, the subcutaneous dosing group appeared to do numerically better than the PO group with an odds ratio of 1.7. You'll note that the confidence intervals do cross 1, and so this is not a statistically significant result. My interpretation is that with the relatively small number of children, this study was underpowered. Again, I think there's a numerically very strong trend in favor of sub-Q dosing. Time to remission was delayed in the PO group, and height velocity was lower in the PO group. And so the recommendations by the authors, which I agree with, is that in Crohn's disease, methotrexate should first be commenced subcutaneously with the consideration to switch to oral form in children who achieve complete clinical remission, while at the same time closely following their inflammatory markers and growth. All right, moving on to methotrexate monotherapy in ulcerative colitis. We all sense and feel the urgent need for effective, safe therapies for pediatric patients with ulcerative colitis, and there is now emerging very strong evidence for the use of methotrexate monotherapy in Crohn's disease, based both on adult randomized trials as well as abundant pediatric observational studies that we've just reviewed. And so what about methotrexate monotherapy in ulcerative colitis? The METEOR study was an adult UC induction study recently published in Gastroenterology. This was a randomized controlled trial of 111 adult patients with steroid-dependent ulcerative colitis. Patients were randomized to methotrexate 25 milligrams sub-Q once a week versus placebo, and all patients were initiated on a steroid taper. The main outcome of this finding was a co-primary endpoint of both clinical and endoscopic remission. And as shown here, 32% of methotrexate-treated patients achieved this induction outcome compared to 20% of placebo patients, resulting in an absolute risk difference of 12%. You'll note from the p-value here that this was not statistically significant, and therefore this trial failed its primary outcome. I will also note that this study was way underpowered. I think a 12% absolute difference is quite clinically meaningful, and when you do the math, this corresponds to a number needed to treat of 8.3. So I would not necessarily dismiss this as a negative study. And when you stratify the co-primary outcome into clinical remission and mucosal healing, You can see on the left, the clinical remission outcome was statistically significant with an even greater delta between the two groups. But even when you look at mucosal healing, while not statistically significant, the difference in both groups is still about 10%. Again, I would posit this is clinically meaningful. So that was the induction data. What about the maintenance data about methotrexate in adults? The MERIT UC study is being led by my colleague Hans Herfarth, and it's a study of 179 adult UC patients. All patients receive open-label induction with methotrexate, 25 milligrams sub-Q once a week. Patients with a clinical response or remission and off steroids at week 16 undergo randomized withdrawal. Some patients will continue methotrexate, and other patients are randomized to placebo. All patients are treated with concomitant 5-aminosalicylates. The primary endpoint for this study is relapse-free survival and no steroids between week 17 and week 48. And I know Hans is very happy that the final patient is undergoing follow-up at the moment. He has allowed me to share the results of the open-label induction. This is very consistent with the METEOR study. About 51% of patients were induced into a clinical response and 30% induced into a clinical remission. We know much less about the use of methotrexate in pediatric ulcerative colitis. These data here are from a retrospective study of 32 children with ulcerative colitis, 28 of which were intolerant or refractory to thiopurines. The intervention in this series was IM methotrexate at a mean dose of 13.7 mg per meter square per week. And as you can see from the figure here, this displays clinical remission as measured by a PUCAI at 3 months, and the clinical remission rate was 31%. And this was relatively sustained over time with 28% PUCAI-based clinical remission going out to 6 and 12 months. Nevertheless, I will caution you from the guidelines that there really is very limited data on the use of methotrexate in pediatric UC. Dan Turner and his group concluded the presently available evidence is insufficient to recommend the use of methotrexate in pediatric UC. I think as the adult trial data become more mature, we'll have to continuously rethink this and begin to analyze some of our multicenter cohorts as we have continued off-label use of methotrexate in UC. I'd now like to move on and examine the question of methotrexate as a combination therapy with anti-TNF, and you all know the rationale behind this. Not all patients respond to anti-TNF, and many patients experience a secondary loss of response, much of which may be antibody-mediated. We know that combination therapy in adults with infliximab and azathioprine improves both the response rate as well as the reduction of antibody formations. However, there are significant concerns with the use of thiopurines in pediatric patients. And so the logical question is, can combination therapy with methotrexate provide similar benefits with reduced risk? The COMMIT was an adult randomized trial. This was a 50-week double-blind placebo-controlled trial comparing methotrexate and infliximab to infliximab alone in 126 Crohn's disease patients. All patients had initiated prednisone within 6 months prior to randomization, and prednisone was tapered by protocol and discontinued by week 14. The primary outcome was a good common sense clinical outcome, time to treatment failure, defined as a lack of prednisone-free remission, CDAI less than 150 at week 14, or failure to remain in remission through week 50. This was about the most negative study I've ever seen, with really zero difference between the intervention and placebo groups as it relates to the clinical outcome. When you examine the data more closely, however, and look at infliximab trough levels and antibodies, you can see a numerically but not statistically significant improvement in infliximab trough levels in the combination therapy group as opposed to the monotherapy group. And you can also see higher levels or lower levels of antibodies in the combination therapy group. All right, what do we know about this topic in the pediatric literature? This was a 10-year single-center retrospective cohort of 188 patients initiating infliximab. 44% started on low-dose oral methotrexate, 24% started on methotrexate at some point after induction, 23% were on infliximab monotherapy, and 9% on concomitant thiopurines. In this single-center study, there was no difference observed in sustained durable remission or the time to loss of infliximab response. It's also worth noting that although ATIs were not routinely measured, there were no differences observed between any of these groups in that study. We have another multi-center prospective cohort study to sort of gain insight from in the pediatric literature. This was a study of 502 subjects who completed a 3-dose infliximab induction, and immunomodulator use was classified into 3 groups: no concomitant immunomodulators, immunomodulators used for less than 6 months in duration, or immunomodulators used for more than 6 months in duration. And the primary outcome was continuation durability of infliximab. I'll show you the methotrexate data first and caution that this is only in males because in this registry there were very few females treated with methotrexate. There appeared to be quite convincing superiority for the methotrexate group greater than 6 months compared to methotrexate less than 6 months or no immunomodulators. And the next slide compares methotrexate concomitant immunomodulator therapy with thiopurines, and again showed a benefit of methotrexate over thiopurine use. Again, very much in contrast to some of the adult clinical trials that we've seen. So what do we know about infliximab levels and antibodies in pediatric IBD? The pediatric data is mixed. At the World Congress, the group from Cornell presented a small study which showed a positive effect of combination therapy preventing antibody formation. And there's a oral talk on this topic in our next session later today, and I don't want to steal that talk's thunder, so stay tuned. In summary, I think we really are at a position of equipoise as it relates to combination therapy with methotrexate. We have an adult trial which demonstrated no benefit in induction and maintenance of clinical remission, though did prevent the formation of ATI, and a number of emerging pediatric observational studies which by and large show mixed results. And so what do we need? We need a tiebreaker. And I'm pleased to announce that the combined study is a 40-center, multi-center, randomized pragmatic trial to compare anti-TNF monotherapy versus combination therapy with an oral low-dose methotrexate. We have enrolled our 5th patient this week. It's a pragmatic trial. We have very few inclusion and exclusion criteria: age less than 21, diagnosed with Crohn's disease, starting an anti-TNF, and no contraindication to methotrexate. Patients will be followed in the context of everyday clinical care for a 2-year period, and at week 104, we'll assess both induction and maintenance of remission, as well as a host of patient-reported outcomes and infliximab and adalimumab levels and antibodies. So in my remaining 2 minutes, I'd like to move your attention to some of the safety considerations. These are data from the original adult Fagan induction study from 1995. You can see that the highest number of adverse events were, as expected, nausea and vomiting. But again, there were actually very small differences between the placebo rates and the methotrexate-treated rates. If you sort of scan down the entire list of adverse events, the only one that really pops out as a major difference between placebo and methotrexate is the elevation of liver enzymes. What about in pediatric data? This is, again, Dan Turner's pediatric retrospective cohort study, and you can see about 50% of kids treated with methotrexate will receive or will experience one adverse event, 8% 2 or more. And when you scan down the list of adverse events, they largely relate to elevation of the liver enzymes or nausea and vomiting. A word about pregnancy. So you all know that women who are started on methotrexate should not get pregnant. I think the jury is still a little bit out in terms of males. When you look at the product label, based on expert opinion, the product label says stop methotrexate at least 3 months prior to planned pregnancy. Emerging data, however, since that time really does suggest that methotrexate is actually safe in men who are fathering children. A study published several years ago was a retrospective cohort study of 113 low-dose methotrexate exposed patients and was relatively safe. And just this year at AIBD, there was another abstract on the topic. So again, I think the tide will change and we will realize that methotrexate is safe in men. And here's my last safety slide, and of course the elephant in the room, malignancy. From this nice review article, I'll quote two aspects. The risk of lymphoproliferation associated with methotrexate use is unknown in IBD, but in rheumatoid arthritis, reversible polyclonal EBV-associated lymphoproliferation has been reported, but no excess risk of lymphoma has been demonstrated in nationwide cohorts. So in summary, methotrexate is effective for both induction and maintenance of remission in Crohn's disease. Sub-Q may be marginally superior to oral, and consider starting sub-Q with a consideration of a PO switch later in patients who are doing well. Emerging data suggests that methotrexate may also be effective in the induction of remission for adult UC. The maintenance study is near completion and pediatric data remain limited. Methotrexate as a combination therapy with anti-TNF, the data remains inconclusive, and our combined trial is underway. And you all know the safety concerns, liver enzyme abnormalities, and nausea and vomiting, which can be managed. No known increased risk of malignancy, and of course, avoid pregnancy in females. Thank you very much.